Topic Tuesday. So uh, there were we've been having some blog posts about the aortic root. Is the part of the aorta that is the closest to the heart base itself, and it's the part that's more susceptible to the high pressure of the blood pumping out of the heart. So that's where most people have their dissection, right there at the root. When an aneurysm develops in the aortic root, your doctor may either recommend you undergo surgical evaluation or recommend routine imaging with the CAT scan. The decision when to undergo surgery to repair an aortic root aneurysm will depend on several factors, including your age, your past medical history, family history, whether or not you have a connective tissue disorder, and of course, the actual size of that aneurysm. In general, for a healthy adult who has no personal or family history of aortic dissection or connective tissue disorders, the surgery may be recommended once a root aneurysm reaches about 5.5 centimeters, and that's pretty much the standard for the entire aorta. And then they included an article from the Cleveland Clinic, which we trust them. We get a lot of our information from them. But the article basically says that there's two main categories of aortic root surgery: aortic root replacement, which is named after the Dr. Bentel, and valve-sparing aortic root replacement. I know it mostly as the David procedure. I haven't heard it as that other one. The Bentel procedure will replace your entire aortic root, including the aortic valve, depending on your age and risk factor. And your doctor may recommend either a new mechanical aortic valve, which needs blood thinners, or a bioprosthetic valve, which is less durable than the mechanical valve, but will need you to take blood thinners. So when I had my valve replaced, so I know they said this is usually all in one surgery. So I had my dissection. So we repaired the dissection. Then I developed what they call a pseudoaneurysm right at the root. So right between where it comes out of the heart and where my repair started, I ended up with an aneurysm. When they went in, they decided to also replace my valve. And I knew they were going to replace the valve. I wasn't given a choice. A lot of people say that their doctor will give them a choice between the two. I wasn't given a choice. And it does say that with the bioprosthetic valve, which they just call it a tissue valve. Typically, I don't usually see it called that. I usually see it in the literature. When I read articles, it's called a tissue valve. And I'm not on a blood thinner. I've always been on a blood thinner for about 6 months after. I've had 3 surgeries. I'm on a blood thinner for 3 months after, but with the tissue valve, I'm not on a blood thinner continuously. So I'm sure it's different for everybody. But the images are always great for us to see because it helps us understand. The valve-sparing aortic root replacement includes either the Jakob or the David procedure, and involves replacement of the diseased aorta while keeping your aortic valve in place. And a lot of times they will do that when you have your emergency dissection surgery. They'll go in, they'll do what they need to do. And from attending some of these conferences, it's common practice, or best practice is what I should say. It's best practice for a surgeon to set you up for a second surgery, knowing down the road most people will have a second surgery. So that apparently is very common practice now, and it's written about a lot in the procedures, and it's talked a lot about in the conferences, the different ways to do that for your next surgery to be even more successful. However, the VSARRs are very technically challenging operations and may not be recommended in numerous situations, such as if your valve is too diseased or preserved. So what I find is they do try to preserve your valve, especially in the dissection emergency surgery, and then they have to go back in later and do that. So there's some pictures there. Of course, while reviewing your surgical options with your medical team, ask questions. Always go with as many questions. Find out what they recommend, why they recommend which type of surgery or valve replacement and why. Ask them about their experience performing these types of surgeries. And as we all know very well, there is no one size fits all with the aorta. So be sure to find a plan that works best for you. I would like to add from personal experience. So I first had breast cancer, and I learned to ask this question during that time, and I've carried it over to cardiac world. And it's been very interesting to me when I sit with a doctor and they recommend a certain procedure, big or little, sometimes even test. And I say to them, are you making this recommendation based on my insurance, what my insurance will pay, or are you basing this on best practice? And I can think of two big times, that the answer was the recommendation was based on what my insurance would pay. And then I had to have a discussion with them of, okay, you need to tell me both, because it should be up to me whether or not I want to pay out of pocket for the better procedure. I also had this experience in the cancer world, with an infusion that I get every 6 months. The insurance would not pay for the one that was better suited for me, unless my doctor jumped through lots of hoops. So I convinced my doctor that he needed to write the letters and he needed to do what needed to be done for me. And I ended up with the better option. So you really do have to advocate for yourself.